So Matt, there were several abstracts at this meeting looking at combination. So that's the next obvious question. We'd like to be able to treat patients and give them a treatment-free interval. So maybe you can comment on where the field is going and what's the strategy for combination therapy.
So this is becoming a complicated area. We had a session yesterday with a number of these, and it's a bit of an alphabet soup. So, I think some of the key agents to consider are ibrutinib, venetoclax, and obinutuzumab, and you're seeing all different versions of combinations of these. So some studies, like one that was presented from your center, was looking at the doublet of ibrutinib with venetoclax without a CD20 antibody. The group at Ohio State presented 3-drug data with ibrutinib, venetoclax, and obinutuzumab. We've seen some data now from the UK group and Pete Hillman looking at their Clarity study at ibrutinib and venetoclax. And there's different durations of therapy based on various factors. So, I think that the jury's still out as to which approach is best. These are all early, mainly phase 2 studies. I can say that they all look very promising. We're really seeing some dramatic rates of MRD negativity. Another one to mention is the venetoclax obinutuzumab study, the phase 1b study that Ian Flynn presented here, which showed a 63% rate of bone marrow MRD negativity in a frontline CLL population. I think that's very impressive without the need for chemoimmunotherapy. So I think as we move forward, it's going to be a challenge to figure out which of these regimens to take into the phase 3 setting. There have been efforts now to expand the FLAIR study in the UK to include venetoclax-containing arms. The German CLL-13 study, as was mentioned before, is now going to also compare to chemoimmunotherapy. So eventually we'll have some answers, but right now we just have a lot of very promising phase 2 data. It's challenging because right now in the US we don't have access to combinations of these agents, so we can't really do this off-label. I don't think most insurers would pay for both novel agents at the same time. So I think these data are going to need to be maturing more before we see them in practice.
And what will you be looking for in terms of that strategy? How will we show that that's an advance with the combinations?
So I think particularly having a time-limited therapy with novel agents will be a major advance compared to having to continue patients on ibrutinib monotherapy, for example. But again, I think it depends on the patient population. So going back to what Steve was saying, if I have an 82-year-old who wants to have good disease control, I think ibrutinib monotherapy may be a great option. But if I have a 62-year-old who wants to live another 30 years, and that might be a patient I want to focus on a time-limited combination approach, get them into an MRD negative state, and then hopefully give them a long treatment-free interval before they may need treatment again.
In all of those trials that were presented, and you're right, it was an alphabet soup, and all were very impressive. Whether it's upfront or relapse, the median age was in the 60s, right? I mean, these are the folks that we have to really focus on, especially with the combinations, especially with time-limited therapy. And to Bill's point, the ones really getting to undetectable disease, because that's going to at least translate into prolonged benefit, I think. So I think the German trial, which is multi-armed as it tends to be, I think that might be a registration trial, and in the upfront setting. And the next planned U.S. intergroup trial, for the younger patients, the follow-up of the FCR versus IR is planned to be ibrutinib obinutuzumab versus ibrutinib obinutuzumab venetoclax. A year of venetoclax, I think 18 months of ibrutinib, and then stop. So I think it's going to be exciting. I think a year from now at ASH, we'll get some more good data.
And of course, just as we start to work all of this out with the first generation agents, we have all these exciting second generation agents, and whether acalabrutinib and ublituximab and umbralisib will make a difference in these types of combination regimens is going to keep us in business in clinical trials for a long time.
The thing that I would add with regard to your comment and the age, so I think it's very important for us to develop regimens that are appropriate and effective and tolerated in the most common population of patients we have. Just with our ibrutinib venetoclax experience, it appears that combination is equally well tolerated in patients who are over 70, for example, compared to younger than 70, and it's active. So I think from my own perspective that we're moving into this era where we can talk about MRD negative remissions in 75-year-olds.
And stopping therapy because of that. Which is a big advantage.
And in your frontline population, by 12 months, 100% MRD elimination. That was
But it was an early report, and there were very limited numbers that had gotten all the way out. So it's an ongoing trial. Patients can get up to 2 years of therapy. So we'll see where there's more work to do.